Hi, Katie.
Hi.
Thanks for joining us. It seems like you've had a big day.
It's my fourth committee in 2 hours, so that's eventful. Oh, there's the link. Okay.
And so we are talking about 222 here. I believe this passed out of Human Services unanimously. So,
I wasn't in the room when they
Okay.
voted, so I don't know.
Sorcia will look into that one too.
1100.
1100, see? Great, I remembered that one right. An act relating to reducing overdoses.
Still logging into Zoom here.
Since we're not gonna take a great deal of testimony on this, just like a little public service announcement. I don't know if anyone, there's been a few articles recently, but our death by overdose rate keeps on skyrocketing here in our lovely state of Vermont.
Okay. Ready to go. Katie McGlynn, Office of Legislative Counsel. I should say right off the bat, I also have a bill on the Senate floor, so I might wrap up here and run over there.
We have backup for you.
Oh, great. What I might do is I put together a section by section summary, and I wonder, since you're interested in sort of very specific portions of the bill, if that might be an easier way to.
That would be delightful, thank you.
Okay, let's do that. There it is. And do you want me to kind of run through each section or just bring you right to the sections that I think?
I think running through the whole thing on a high level is helpful because we need to vote on the whole thing.
Okay.
But only want to see sort of legislative language on the
Okay.
fee fund.
Sure. So in section 1, we have updates to the unused prescription drug disposal program to also include needles and syringes. In section 2, there's a requirement to have regional stakeholder meetings with regard to public needle and syringe disposal programs. And by next January, the health department would come in and present information on those regional stakeholder meetings to the subject matter committees. And then section 3, there's a fiscal year 24 appropriation of $150,000 appropriated from the Evidence-Based Education Advertising Fund to the Health Department to provide grants and consultations for municipalities, hospitals, community health centers, and other publicly available community needle and syringe disposal programs that participated in the stakeholder meetings that were required pursuant to the last section. In section 3A, it's the prescription drug manufacturer fee, and the proposal is an increase from 1.75% to 2.25%. And in section 3B, we have a presentation coming back next February from the health department in consultation with stakeholders regarding unmet needle and syringe service needs, resources required to ensure equitable access to needle and syringe services, and who is best positioned to provide needle and syringe services. Section 4 is relates to the prevention and treatment of opioid-related overdoses. This updates an existing section of law that pertains to opioid antagonists, and some of the specific changes within that section require the health department to include the status of legal possession of substances and harm reduction supplies to any education and trainings it provides. It requires the health department to distribute opioid antagonists to assist those at risk of experiencing an opioid-related overdose. And it requires the health department to establish an opioid antagonist dispensing kiosks and locations accessible to those at risk of experiencing overdose. This section removes the requirement that a healthcare professional may only prescribe, dispense, or distribute an antagonist to individuals who have received education in a manner approved by the health department. And it removes the requirement that an individual must call for emergency medical services after administering an opioid antagonist. Section 5 exempts other harm reduction supplies from the definition of drug paraphernalia. The purpose of this is to exempt harm reduction supplies from penalties related to selling drug paraphernalia to minors. Section 6 pertains to prescription drug coverage. It prohibits a health insurer or a health benefit plan offered by an insurer or a pharmacy benefit manager on behalf of a health insurer covering prescription drugs from using step therapy, fail first, or other protocols requiring documented trials of medication before approving a prescription treatment for substance use disorder. So There, you'll see corresponding sort of pairs of language. One pertains to private insurers, one pertains to Medicaid, but the idea is that some forms require a patient who maybe has an allergy to a particular medication. They may say, I have an allergy, but the physician or healthcare provider still has to say, I have to, you have to try it and I have to make an observation. So this would eliminate that requirement, that if the person says I have an allergy, that the provider would take them at their word. Section A, 6A, the phrase medication assisted treatment is replaced with the phrase medication for opioid use disorder.
That's nice.
And section 6B, this pertains to opioid use disorder treatment systems. So it amends rulemaking authority to provide both the health department and DVA greater flexibility in maintaining a reasonable system of opioid use disorder treatment. It uses more expansive language as to who may dispense substances to treat opioid use disorder. It replaces physician or advanced practice registered nurse with healthcare provider. Subsection D it adds subsection D to allow controlled substances for use in opioid use disorder treatment to be prescribed via telehealth in accordance with federal requirements. And it adds section E to prohibit DVA from requiring a healthcare provider to document a patient's adverse reaction to a medication prior to prescribing an alternative medication for opioid use disorder to the patient. So that's the second half of that pair. In section 6C, the only change is to replace MAT with medication for opioid use disorder. It's a corresponding change to section 6A where the definition was changed. In section 7, medication for opioid use disorder, this requires AHS to provide coverage to Medicaid beneficiaries for medically necessary medication for opioid use disorder when prescribed by a healthcare professional practicing within the scope of the professional's license and participating in the Medicaid program. And pending approval from the Drug Utilization Review Board, it requires the agency, this would require the agency to cover at least one medication in each therapeutic class for methadone, buprenorphine, and naltrexone as listed on Medicaid's preferred drug list without requiring prior authorization. And then in section 8, we require recommendations by November of this year from the Joint Legislative Oversight Committee to the policy committees regarding the legislative action needed to ensure continuity of treatment for individuals reentering the community after a correctional setting, including elimination of prior authorization for medication for opioid use disorder. Section 8A is
The acronym is not as good, though. I like
it doesn't roll off the tongue the same way. I know I have to retrain my brain a bit on that one. Section 8A is a report. It requires DVA in consultation with individuals representing diverse professional perspectives to research the feasibility and costs of administering a gold card program for substance use disorder treatment in which AHS shall not require a healthcare provider to obtain prior authorization for substance use disorder treatment if, in the most recent evaluation period, the agency approved or would have approved not less than 90% of the prior authorization requests submitted by the healthcare provider for that medication. And then DVA's research would be submitted to the Drug Utilization Review Board and Clinical Utilization Review Board for review and recommendations, and DERB and CURB, the acronyms, their review of that research and their recommendations would come to subject matter committees by April. I have of this year, is that right? Let me walk through this and then I'm gonna double check. Section 8B is a rulemaking section. This has a financial impact. This directs DVA to amend its rules to enable healthcare providers and office-based OTPs, office-based treatment programs, to prescribe 24 milligrams of buprenorphine without prior authorization. That creates parity with the spokes, with the hubs. And then in section 9, we have language with regard to recovery residences. It It defines what a recovery residence is, and it also requires that in all municipalities, a recovery residence serving not more than 8 individuals be considered by right to constitute a permitted single-family residential use of property. And then we have a repeal. So this language would remove the future repeal of the buprenorphine exemption, meaning if passed, the section would be a continuation of existing law and that there would not be criminal penalties for possession of 224 milligrams or less of buprenorphine, except there are certain specifications for individuals under 21 years of age and then under 16 years of
We
age.
passed that temporary provision 2 years ago, 3. I remember the debate very clearly, but
I believe it was 2 years ago. That sounds right. And then effective dates, we have our section on medication for opioid use disorder taking effect September of 24, and everything else takes effect on passage.
It is 24.
It's just a typo in the section by section. Better in the section by section than the bill.
absolutely. Thank you. Any questions for Katie? Yeah.
So where's the fiscal?
We're gonna get to that with Jen. Jen is actually doing that section,
Okay.
right? That's the plan? Is that Jen's? Talk about that?
Jen is the expert on the evidence-based education advertising fund, which is where the appropriation comes out of. So she can cover that.
Nolan and I are gonna tag team.
On section 3 and section 3A.
And there is this.
Okay, great. Okay. So anything else for Katie? Yeah.
Is there any discussion about how this interacts with the medication-assisted treatments within corrections?
I was not present for much of the conversation in the committee. The only piece that specifically pertains to corrections is that one report back on continuity of care for people exiting a correctional setting.
Does this influence medication-assisted treatment within corrections? Do the same things apply? I don't know.
This doesn't change what's currently happening in a correctional facility.
Because that's not under Medicaid, right?
Excuse me?
Is that funded by Medicaid, corrections?
I don't think
Medical
so.
treatment? That's what I thought.
No.
Okay, so it wouldn't change. Okay. Thank you very much. Really appreciate it. Enjoy the Senate.
Okay.
And for the two of you, do you have a preference of who jumps in first? My preference is Jen.
We decided.
Yeah, you can, sure.
And are you gonna want, like, if I'm looking at statute, do you want me to put that up?
If you don't mind, that would be great.
Fine, let me just get. So just invite back.
So we're gonna split this up. Jen's gonna walk you through the statute and then I'll walk you through the numbers.
Serge, can you maybe resend me the, oh, nope, I saved it, never mind. I knew I did something very clever with it.
This is like old times for us. We've sat at this table together for 16 years.
Aw, glad we could recreate that.
Yeah, right?
Jen's getting teary from it. Look at her.
Yeah, I can tell.
Yes,
Like Nolan,
Getting-
you're late. Sorry, on the
No.
record
I
today.
feel like Noah and I have already forgot.
I'm getting irritated with my automatic unmuting.
That's why she's crying. It's her computer, not me.
Take over your desk in your absence.
Well, hello again, Jennifer Carby from the Office of Legislative Counsel.
Nolan Langwell, Joint Fiscal Office.
So we are here to talk to you about the funding piece of H 222 that Katie just went over the language on. And so let me put up statute. Oops. Done, yes. All right, so this is 33 VSA, section 2004. It is the manufacturer fee, and it is, and you'll see, it says it at the bottom, and the following section 2004A is where the Evidence-Based Education and Advertising Fund is established. And so the provisions are basically mostly mirrors of each other, except the fee itself is established in this section. So that's why we're looking at it. So under this provision, annually, each pharmaceutical manufacturer or labeler of prescription drugs that are paid for by DVHA, the Department of Vermont Health Access, for individuals participating in Medicaid, Dr. Dinosaur, or VFarm, they have to pay a fee to the Agency of Human Services. And it is an amount of 1.75, 1.75% of the previous calendar year's prescription drug spending by DVHA, and will be is assessed based on manufacturer labeler codes that are used in the Medicaid rebate program. That's how they identify which manufacturers. So 1.75% of DVHA's pharmacy spending, prescription drug spending, and it gets allotted or apportioned among the drug manufacturers. The fees that are collected under this section are allowed to be used for a number of purposes, and these are the ones that are also cited in the following section. So they can fund collection and analysis of information on pharmaceutical marketing activities under 18 VSA sections 4632 and 33, which have to do with gift disclosures of allowable gifts by prescribed product manufacturers and some marketing activities by the manufacturers. Analysis of prescription drug data needed by the Office of the Attorney General for enforcement activities. It can be used for the Vermont Prescription Monitoring System, established in Title 18, the Evidence-Based Education Program, established in another part of Title 18. This is what's sometimes referred to as academic detailing or counter detailing. It's a state program to provide sort of impartial or objective information about prescription drug options to prescribers. It can be used for state unused prescription drug disposal initiatives, prevention of prescription drug misuse, abuse, and diversion, the Substance Misuse Prevention Oversight and Advisory Council, treatment of substance use disorder, exploration of non-pharmacological approaches to pain management, for a hospital antimicrobial program for the purpose of reducing hospital-acquired infections, for the purchase and distribution of fentanyl testing strips, the purchase and distribution of naloxone to emergency medical services personnel, and any opioid antagonist education, training, and distribution program operated by the Department of Health or its agents. So that is the list of authorized uses of fees that are deposited into this Evidence-Based Education and Advertising Fund.
To editorialize, that seems like really important places to be spending money right now, given all that is happening in our communities.
Well, one thing I think you can see from all of these is that there's a connection between use or misuse of prescription drugs and the purposes for which the fund can be used.
Thank you.
So,
I'm going to take mine down and you.
sure. So Jen and I were actually Jen, I should say Jen was looking this up right before we came on. And we wanted to remember when it went up last. And so it went up from 0.5 to 1.5 in 2016. And it went up again in 2019 from 1.5 to 1.75. So I'll add that to my memo, which, speaking of, there is a memo on your webpage. The first page kind of summarizes what Jen just talked about, which is the allowable uses for the fund.
The prescription drug manufacturer fee brief.
Yes.
Just because you've been in here twice, I want to make sure we're on the same.
Yes.
Thank you.
So first page just summarizes what Jen has already said. I think I was multitasking. I'm guessing Jen mentioned that the fee goes into the Evidence-Based Education and Advertising Fund. So you're starting to put the second page of the memo. I have it broken down revenues and expenditures for 22, 23, and 24. So in fiscal year 22, revenues from the fee were 3.8 million. The expenditures were 3.5 million. And I put a chart because just to give you an example of these are actual expenditures. This is the actual spend from that fund for that year. 23, we're still in that year, so I can't tell you what it was spent on. It's estimated to bring in between 4.7 and 4.8 million. And What's that?
putting this up.
Okay. And the governor's budget is 23, the 23 appropriation that we passed for 23 is $4,814,281. For fiscal year 24, the governor's budget recommendation is approximately 3.5 million from the fund. And we estimate it'll still bring in about 4.7, 4.8 again. According to the health department, the fund has an unobligated balance totaling 2.6 million, and that's after taking into account the revenues coming in and the governor's recommendation.
And my understanding from the Human Services Committee is that they have plans for more of this fund related to all of the different harm reduction pieces that are both in this bill and still in the works for the year.
And to that point, if you go to the fiscal note, or you don't have to, but the increase of the fee from 1.75 to 2.25, which the bill does, would bring in an estimated $1.3 million on top of that.
Thanks. Any questions? Yes.
1.1 to 2 million is a pretty broad range.
What's that?
We're
Oh, that's in the fiscal note. That has to do with the Medicaid prior authorization piece.
There's no way to,
No.
and that's an appropriations section more than a Ways and Means section. In a vein, what's the word? Whatever.
I do second
Scope.
your
Yes.
high level
Yes.
with the record deaths. This seems like a really important place to be investing resources.
Okay, thank you. If you two could hang out for a bit.
Sure.
Um,
Well done.
Mr. Englander? Dr. Englander?
I'm a doctor of laws.
Okay. Attorney Englander, would you like to join us?
I do ask no one to call me doctor, but that's.
I get that one too. I get everybody's jokes. When they're bad, I get.
Are you saying my joke was bad earlier?
No, I'm saying your joke was great. His was bad.
Okay, good. Hello, welcome to our committee.
I was thinking about which joke was better. We can talk about that later. Good morning.
Good morning.
My name is David Englander. I'm the Senior Policy and Legal Advisor to the Department of Health, and I'm delighted to be before you. I have this Pavlovian response to being in this room. I want to talk about vaccine safety,
We do not want to talk about that under.
which is why I was not.
I'm from Brattleboro. Serious issue down there.
So I'm delighted to be here and answer your questions and to discuss this. I'm very grateful, of course, to Katie and Jen and Nolan for walking through the numbers, so I don't have to. For the most part, I was prepping last night, and public math is one of my great fears. How can I be helpful to the committee?
I guess I would ask you your thoughts on being able to spend this new revenue on behalf of saving people's lives in our state where people are
Sure.
working.
So,
And I would also ask if you think that perhaps the pharmaceutical companies could bear the cost.
well, I'm not qualified to opine. I think that the public reporting does a good job of answering that question.
Okay.
I'm not an expert.
Okay.
The simple matter is that the governor's office proposes $3.5 million for spending out of the evidence-based education fund, and that the proposed rise in the fee isn't accounted for in that. The department did not ask for the rise, nor do we ask for the $150,000 appropriation for the needle exchange. As Katie described, Katie, who's no longer sitting here, the Department of Health is given several jobs in H222, which the department is supporting in terms of doing public outreach and having public discussions, trying to find the places where we can meet people where they are in terms of both naloxone distribution as well as syringe disposal. As Nolan mentioned, there is $2.4 million unobligated in the fund today. So at this time, until we understand what would be proposed, the department doesn't support the rise because we don't know what the money would be.
And I've heard rumor that the cost of naloxone has gone up quite considerably.
It has.
Can you tell me more about that?
Sure, so I don't have the numbers in terms of the rise. It has risen considerably as there has been novel ways to, I wish I had like naloxone on me.
Oh, I have some in my purse, I
Do
think.
you? Do folks?
I don't actually have my purse today. I left it at home for the first time.
And I left my purse at home.
Okay. Naloxone for us.
Do folks know what naloxone looks like today? That it looks like the one shot like Afrin. It's just something you squeeze.
Yeah, just
Yeah. And up until a few years ago, it was the only thing that could be administered intravenously by EMS. One thing just maybe note historically, which is that when we first started distributing naloxone, it was originally just to community-based organizations. So they get community-based organizations such as the Howard Center, get it from the department at no cost. It's no cost to them. It's no cost to the receiver of the naloxone. As time has gone on, more and more people have accepted the idea that naloxone is a critical piece of harm reduction. So originally, it was just folks like the Howard Center, and then it became police departments, and then it became EMS. And so all of this distribution, this goes through the Department of Health and paid for by the fund. At this time, between the what's in the manufacturers, we colloquially call it the manufacturer's fee fund, but it is the evidence-based.
You're welcome to use the
Education.
colloquial term.
I'm sorry?
You're welcome to use the colloquial term. It's fine.
And also with the opioid settlement monies that have come into Vermont, at this time, there is sufficient money in the bank, literally in the bank, to pay for naloxone distribution.
Thanks. Yeah.
So just looking, it looks like the fund, the money that goes into the fund year over year is pretty stable.
Yes.
And yet the governor's proposed budget in FY '24 looks like it doesn't use as much of the fund as it could. And yet I hear you saying that prices for some pretty core pieces of this are going up. Can you give me a read on the thinking on that, or I don't?
I'm afraid that I can't give you a read on. Well, let me say I can speak broadly to it.
Sure.
I don't help build our budget. That's for that.
Like Chris? Or like?
Yeah. Sorry, the answer is that there has historically been enough money in the fund and money built up over time that were unobligated. So when the prices rose, there was sort of sufficient headroom to compensate.
Thank you.
Can you fathom maybe of ways that you could save more lives with more money in this fund? If, say, it was in your budget?
I'm not in a position to
Okay.
to have
Great.
to
Maybe
fantasize,
from-
but I appreciate that intention.
Great. Okay, well, thank you. Yeah. Representative
I
Brennan.
just want to say that I'm getting treatment for cancer right now. And when I came home from having surgery, that was the first step. So I had surgery, chemo, and now radiation. When I came home from having the surgery, I was given a prescription for 6 morphine pills, of which I still have 2. And when my husband went to pick them up, they made him take one with naloxone. 6 morphine pills. So I'm wondering if there's really such a need for this thing. I don't have a drug problem.
Sure.
I don't have any other painkillers that I take regularly, nothing except for Advil once in a great while. But they made us take that.
So would you like me to
Yes,
offer a thought?
respond.
Sure, I'm happy to. We have moved away from a regime where providers are looking at persons and making an assessment as to whether or not they're likely or not to be somebody who has a substance use issue. What we do is we look at the behavior of the prescriber and say, if you are prescribing, if a person has been prescribed opioids and they're getting a benzodiazepine or the other way around, a provider has to write a prescription for naloxone. The patient's not obligated to fill it. The provider is obligated to say, you now are on a benzodiazepine and an opioid, and that combination with alcohol is the number one source of overdose deaths in Vermont. 5 years ago, 2/3 of all deaths where people died at home with a combination of those three things. So it's a harm prevention idea that is not it's specifically not intended to target those who might be perceived as someone has an issue, but rather that it be a general harm reduction strategy. But you should know that you're not obligated to fill it. It's simply, it'll.
That we didn't know. My understanding is the impression was that he had to take it. I wasn't there. He went to pick up by himself. But it's made me wonder ever since then, if this naloxone really is needed to be spread out among the population like that. Because there's one instance where it's never been used and there was no threat.
I carry it in my purse because I don't ever want to be in a position where I can save someone's lives and I didn't have it in my purse, you know?
Yeah.
And so your grandkids could come over and find the bottle, and then you're gonna want to have it there.
And if I may,
Sorry.
I was just told a story about a week ago of a fellow lawmaker out knocking doors trying to get her election won and came across somebody near death in their car and was able to administer naloxone, which was, you know, she felt really grateful that it was there. So like someone just like you or me that doesn't have substance use disorder, doesn't have someone around them that feels at risk, but was in the right place at the right time with the right drug.
What's the shelf life for that?
The current product is for Narcan, the one shot Narcan is 2 years.
Thank you very much for joining us.
Thank you.
Madam Chair, I move that we vote out H-222 favorably.
I'll second.
Thank you. Representative Demrow moved that we find 222 favorable. Representative Andrews seconded. Do we have any discussion?
What draft is it, do we know?
As
4.1.
As passed. 4.1, thank you. As passed by Human Services with no amendments. Seeing no discussion, if the, what are you called? The clerk, could please call the roll?
Andrews, yes. Anthony,
Yep.
Beck. Sorry, didn't look up. Brannigan,
Yes.
Demrow,
Yes.
Maslin.
Yep.
Meadows,
Yes.
Odie,
Yes.
Sims,
Yes.
Taylor,
Yes.
Canfield,
Yes.
Kornheiser,
Yes.
1101.
Thank you, everyone.
Molly.
So we are, I am going, if folks could pay some, we're gonna break for lunch. If folks could pay attention to your email or notes on the floor, we might wind up breaking to come back to do some more work on veggie, depending on what's happening on the floor. I promise I won't pull people in during the gun bill or anything like that, okay?